I'm Sheital Bavishi. I'm one of the PM&R or physical medicine and rehab doctors or physiatrists. We're called by all of those terms here at Ohio State. Like Dr. Guthrie, I did my residency training in physical medicine and rehab, and then I did fellowship training in brain injury medicine. And so when I came to OSU in 2013, and as everyone says, I'm the medical director of the brain injury program, but I see patients with brain injuries from concussions all the way to the most severe brain injuries and disorders of consciousness. So really what I want to do today with my talk is kind of pull together what Dr. Guthrie talked about, hearing Dawn's story, and then hearing what Rachel and Casey do, kind of clinically, how can we look at this whole care? So when we start thinking about post-concussion syndrome or post-concussive symptoms, so I put this in from a concussion standpoint because majority of people that sustain a brain injury, whether it's through violence or through other traumatic means, they will sustain a concussion. So that is, like Dr. Guthrie was saying, the mildest forms of brain injury. But really from mild all the way to severe, people will have these same symptoms. And so when we're looking at, what symptoms am I thinking about when I have someone coming in? What is the constellation? And I always tell people the brain is like the computer hard drive to the body. It controls so many processes, not just from physical, but also cognitive, psychological, but also, some of our senses as well, with balance and vision and hearing as well. So I have kind of slides up here that'll be good references for people. But really, what are we doing when we have someone come through, or if I see a new patient on my schedule that has a new patient for a brain injury or new concussion? There's different assessment tools that we can use. And so I have two tools up here that we use that are kind of the simplest. And one of the questions that was posed with this is, what tools are done by the individual and what tools are done with the clinician? And so this is a tool, the Rivermead Post-Concussion Symptoms Questionnaire. It is a subjective tool, but it is a tool that's actually done by the individual that's sustained the brain injury. So, and it's really kind of evaluating the symptoms that I had just presented before, 17 of the symptoms, and how often they've happened in the last 24 hours. So this is kind of a screenshot of what the questionnaire looks like. You can get this questionnaire online. You can just Google it and type in Rivermead Post-Concussion Symptom Questionnaire and get the PDF version of it. There's no copyright to it, so anybody can use it. But really what we want to do with this is have the individual tell us how often are they having these symptoms over the last 24 hours, and 0 being they didn't experience any, or 4 it's a severe problem. So that way we can really start tailoring what we're doing from a treatment planning standpoint. So again, like everybody has been saying throughout this, you see one survivor there, that's one survivor. You see one brain injury, that's one brain injury. Everybody's experiences are different. Everybody's recovery process is different. Everybody's baseline brain is different. So we need to know, which, for that individual, what is affecting them the most. So this is a very subjective tool, and it is done by the individual on their own. Now, here at Ohio State, we also have something called the Traumatic Brain Injury Identification Method. So this is really a tool for healthcare and social service professionals. So this does not have to be just done by a physician, nurse practitioner, or another clinician. It can be done with our social service professionals as well. And so it's short and it's structured. This one is different than the Rivermead in the fact that the Rivermead is looking at symptoms in that person at that particular time frame, but doesn't really ask for a history of the brain injury and what people have gone through. So this tool actually is trying to get a lifetime history of brain injury and how many potential insults they may have had, how many potential TBIs there could have been that were previously undiagnosed. So the link below is the website where you can actually get the tool from on our website. And and I'll show you the kind of PDF versions of it as well in the next couple of slides. The big thing though, this doesn't screen for all types of brain damage. So this is mostly the ones that are from traumatic injuries, and not necessarily hypoxia or anoxia, which is what we'll kind of chat about too at the end, because they are, even though they all are brain injuries, because of their different mechanisms, they have different recoveries and different types of symptom complexes, even though some can be very similar. So this is the TBI identification method. Now, this is something that the social service will actually go through with the individual. And so it kind of breaks it into steps about, what you're asking, how you're asking the questions, and then how you're recording it. So you have your steps 1, 2, and 3, and it gives interviewer instruction. So this one is actually done by the interviewer. So that way, they can help guide the individual through some of these, because as you heard from Dawn, people do, after they've had a brain injury, can have trouble with coming up with words, coming up with memories, and being able to really get what their thoughts are out. So having the interviewer being able to kind of help guide the process and get that information is helpful. So again, this is more of documenting and how to interpret the findings. But why is this screening important? And as you've heard today, there's lots of reasons, but really it's the main things are, it's like people sometimes don't know that they've had a brain injury. There are clinicians out there that don't necessarily know how to treat brain injury or identify it. It's not visible, especially from when people have had multiple concussions, they may not have any external visible signs that they've had a brain injury. So I do call it the invisible injury, because it's hard to see. And then the documentation of this history of TBI, if you go to a clinician that doesn't recognize you've had a brain injury, then they're not documenting it. So there isn't potentially that chain of evidence either, or that chain of knowledge that this has happened recurrent times. And so, but you also, as we had presented before with Dr. Guthrie, is like the effects of the TBI can have so many different effects to how the treatments and the services that we provide. And then, there's so many potentials for, like, if they had a previous TBI, how they could recover from a subsequent TBI. So really the screening is very important for us to know if an individual has had a brain injury. And so one of the big questions was, is there objective evidence that someone's had a brain injury? And so one of the big things that we always, consider is imaging. We're always like, we need to get that MRI of the brain. But in mild brain injury or concussions, the brain imaging is not helpful, especially if there's several years or months post-injury. So there are a lot of data out there. I threw one article up here, but about different types of MRI imaging. And so you'll hear about things like an MRI, a magnetoencephalogram, which is the MEG, a SPECT or single photon emission computed tomography, and then you'll hear about DTI, or diffusion tensor imaging. So those are all different kinds of MRIs. However, they're not easy to access. In Ohio, we don't even have anywhere that does a MEG. It used to be done in Cleveland Clinic, but it takes a specific neuroradiologist to be able to read the results. So we don't even have access to a MEG, but the MEG actually shows us the most objective evidence, but we can't access it. And then there's spectroscopy and just the general MRIs. And when you're looking at those, it can show some abnormalities when it comes to somatic and cognitive complaints, but it's less likely to be abnormal. So we don't have imaging to be able to look at that. Now, if someone's had a more severe brain injury, as Dawn talked about, a subdural hemorrhage, those can be seen on a CT scan. And so you can have evidence of those. Typically, those that have intracranial findings or imaging results, they're the ones that will actually have some knowledge that a brain injury has occurred. So one of the other things that we wanted to talk about is, when we talk about all of these symptoms, how can you help your clinician, or how do we help the clinicians understand the difference between PCS, which is post-concussion syndrome, PTSD, and depression? Because a lot of the times, especially when people go in, they're like, oh, well, this is just anxiety, or this is just depression. You didn't have a brain injury. And I say that, and I'm not saying it flippantly, but this is what a lot of people go through, and that's what I hear in my clinics all the time. And the answer is all of three of them have very similar symptom complex. So we really need to be better about trying to delineate what the causes are of each one. And that's where getting a good history, doing that screening tool, and really trying to determine if a brain injury had occurred is helpful. But they all three have very similar symptoms. So what I've done on here is, if you can see my mouse, but I've highlighted or bolded the common, or the ones that are the common throughout each of the different diagnoses. And they're not mutually exclusive by any means, but the answer is they can look very similar. And so having a history of an injury is necessary. And then, from the mental health symptoms overlap. So this is kind of where, so early at the beginning, I have a picture of Dr. Tracy Sheital, and she's one of our neuropsychologists, rehab psychologists. And when we were putting this together for today, we started talking about, how can we help? Because people are asking the question, how can you have trauma-informed care versus neurologically informed care? And the symptoms overlap. They're not mutually exclusive, but they can confound what we're doing. And so really having, access to different health professionals, but this really kind of depicts some of the things that we have from a mental health symptoms overlap. So in the first year, there's an increased risk of psychiatric disorder versus the general population for someone with a mild TBI. Depression is the most common psychiatric disorder following a TBI. Mild TBI and depression, it's up to 35% prevalence rate. New anxiety disorders can be up to 30%. And 15% of mild TBI patients have criteria for acute stress disorder, and then PTSD, of course, in non-combat. In combat we see, but in non-combat that can occur up to 25%. So, we see a huge symptom overlap between TBI and mental health. So some of the treatment strategies that we look at, are first, before we initiate formal mental health treatment, we need to figure out what kind of injury was sustained and what the expectations are regarding recovery. And then education is key for the individuals, because the most effective way to reduce the post-concussive symptoms that could overlap with other mental health is really to educate and to notify the individual that we're looking at all realms of this, and we're going to help treat headaches and vision and other things, but we also want to make sure we discuss your anxiety over the situation, or the depression that can come from not feeling like you were heard before, things like that. So there's lots of factors that we as physiatrists kind of go through and in our education for patients that have had TBIs. So, and then people with moderate to severe TBI will also benefit from this information. This is not just for mild TBI. So from a rehab standpoint, what do I do? What do I do as a physical medicine and rehab doctor? And Dr. Guthrie talked about, the different disciplines that we engage. But we don't only, engage for symptom management and with our PTOT speech and some of our other physicians, but we also need to look at the other piece, case management, social work, vocational rehab, because we want to have good community reintegration. We want to get people back to work. We want to get them back to applying for school and being able to succeed in the future that they want to have. So from a clinical standpoint, I focus on the whole person, top down. I always ask, a multitude of questions. Sometimes I get asked by patients, why are you asking me so many questions? But I really want to know, how has this injury affected them from their day-to-day functioning? What kinds of things do they want to do for their future? And so that helps me figure out, what kind of services and things I need to put in place. And then what are some of the pharmacological and non-pharmacological interventions? And as Dr. Guthrie talked about before, it is a multidisciplinary approach. I, as a physiatrist, I lead that team, but I have a team, and that's what we really need. And so we do have, our general PT/OT and speech, audiology, and then on the other side, we have case managers, social workers, vocational rehab, but kind of some of the main neurological clinicians that we need to have in place as well are a neurologist, and they can help us if, I'm having trouble with managing someone's headaches, or, they have really bad dizziness or vestibular issues. I will consider, referring to a neurologist to help with headache management, and for this, neuroetology, neuropsychology for doing some of that cognitive testing to see if there's accommodations that are needed, see how I can help, guide our speech therapist from a therapy standpoint, see what kinds of potentials there are for future employment or school. That's where our neuropsychologists and rehab psychologists come into play. And then psychiatry, if we need to assist with medication management for mental health. And then physiatrists, of course, like myself and Dr. Guthrie, to really kind of lead this team and create a comprehensive management for our patients. So, one of the other big questions was, what's the difference between rehab and trauma management? And as you heard Dawn earlier state, after leaving the hospital and going to the first follow-up visit, the neurosurgeon's like, oh, your brain's healing, your bleeding has resorbed, and then they're like, you're good. And then it's like, what do I do next? I'm still having difficulties. I'm still having trouble with, memory and word finding and dizziness and headaches and all of that. And at that point, trauma team is there to really do the acute care, to really save your life and take care of you in the ICU. But it's after the ICU is where the kind of rehab comes into place, and that's where you're really thinking about what is the next step. So from the rehab versus trauma management, from a rehab standpoint, I'm looking at the next level. I'm like, okay, the trauma team has done a great job. Those surgeons are fantastic. But now they've treated that, but they haven't treated the consequences or the subsequent things from that. So the next thing that I do is kind of look at, did this person, if there weren't a severe brain injury and they haven't had any care earlier, were they misdiagnosed with post-concussion syndrome and really had PTSD, or vice versa? Did they have, diagnosed with depression or PTSD or anxiety, but really they had TBI? And so we heard this with our Vietnam vets, right? Long ago, we'd always talked about Vietnam veterans having PTSD, but then as research came out, recognizing that more of them likely had blast-related injuries and TBIs. So we kind of can use that same knowledge towards evaluating for if someone's had a brain injury from violence. And so that's really what we need to do. And so the treatment, though, unfortunately, there's not a lot of evidence-based medicine to what I do. And a lot of it is just based on clinical expertise, having that extra training. And there isn't a lot of training for this in medical schools. So I think someone had made a comment about, we really need to teach our general practitioners and about brain injury. And that's 100% true, because it's not something they learn about. But at the same time, it's so nuanced, like we have been talking about. No two brain injuries are the same. You definitely want clinicians that have a little bit more of that ability to use their, not only their clinical knowledge, but their expertise in navigating the fields of someone's brain injury, because it can be very nuanced and it's very individualized. But you definitely want the multidisciplinary approach, and education is the #1 key. If you look at all of the literature and data about brain injury recovery, I think number 1, 2, and 3 is always talking about education. The more you know. I think that was from a PBS Reading Rainbow, but it is true to this day. And so one of the big questions is, though, I presented a lot about traumatic brain injury, post-concussive syndrome, but what do we do and how do we bring this over to someone that's had strangulation or hypoxia or anoxia? It's the same team-based approach. You use the same set of clinicians. You can, but instead of using the River-Mead post-concussion syndrome questionnaire, you could use the TBIID. You can use, some of the other more specific neuropsychological testing that Dr. Shannon, or a rehab psychologist, neuropsychologist would be doing. And the difference with anoxia and hypoxia is there's the potential that MRI imaging can actually really help you, because you can see those areas of anoxia and hypoxia, and they could be longer lasting. So that's in one big difference between that. And then, but the management is the same as traumatic brain injury. You manage the symptoms that are showing up in front of you. So if people are having cognitive deficits, if they're having speech deficits, if they're having visual disturbances, it's the same treatment pathway as someone with a traumatic brain injury. It's just a matter of which symptoms are more prevalent with someone with a hypoxia or anoxia compared to traumatic, but you use the same set of clinicians and the same set of therapists.